All right, let's get started. So welcome everyone. So good to see everyone here. I'm Marie Abraham. I'm the Vice President for Programming and Publications at IPFCC, and I am joined by my colleague, Jasmine Arazi, who is the Program Manager here at IPFCC, and Jasmine will be monitoring the chat, and I'm assuming the chat's going to be quite explosive. So, and then we also have our expert technical support from our colleague, Matt Da Silva, who is our digital platforms manager. So as you know, because you registered, today's discussion is getting leadership buy-in for patient and family advisor and partner programs. So, and we're so excited to see how many of you were interested in this topic. It's obviously very significant to you. I'm glad you're all chatting in your names and organizations and where you're located. So next slide. So we definitely want to acknowledge our PFCC Connect sponsors. So thank you very much to Emory Healthcare, Providence Healthcare, and the University Health. Their support, their continued support allows these conversations to continue. So we're very, very grateful. Next slide. So just to go over a few things, we keep our conversations, we want them to be very active and interactive and informative. We want to hear from you. I will be sharing a few slides, but the slides are really just to get us started on the conversation and provide some context. Then we'll dive into the discussion itself. So we just want to remind every one of our group agreements, be present as possible. So when we move into the discussion part of this session, then we would love it if you could go on video. Participate actively. So we encourage you to be curious, ask questions, but also share your experiences, your perspectives, your challenges, anything that you've faced. You can either chat your questions in, Jasmine will be monitoring, or if you have an idea that you want to share, raise your hand and we'll call on you. I prefer that, by the way, but we'll be monitoring the chat, so that's fine. Let's share space, make sure that we're allowing as many people as possible to contribute to this conversation. Embrace a learning and growth mindset. All of you bring expertise that we really respect, and we've got a lot to learn from each other. I have a lot to learn from you all. And then enjoy the discussion, have fun. We really hope this is informative, but also allows you a little bit of enjoyment in your day. If you experience any technical issues, you can chat with Matt Da Silva. He's in the participant list, so you can chat to him. Next slide. So in the registration process, we asked for some ideas of what you want to hear, what is challenging to you, and here are some of it's not everything, but it's some of what we heard. They just all kind of came to the top for me. So getting leadership buy-in, it's probably why you're all here, is a challenge, right? We know that, but without it, we're not going to move very far. After the pandemic, when advisor partner programs were halted, getting the re-engagement of leadership has been problematic for many of you. It happens without the pandemic, but it definitely happened during the pandemic. In some of our previous surveys, and as well as reading through what you've included in your registration process, a lot of the staff and clinicians and leaders in different areas, they might not be aware of that there are patient family advisor and partner programs, which is really important. So then also, I would say that in order to establish or expand or maintain advisor partner programs, you definitely need to have resources, and those resources come from leadership, which is another reason for getting leaders involved. So another thing is connecting leadership to the PFACs as well as the advisor and partner programs. I think that is something we really need to work on, because leaders need to know what the PFACs and the advisor partners are doing. Many of you reported that getting all leaders at different levels of leadership has been challenging. Yes, this is so true. And I think that it is difficult, but there are ways to do that. And hopefully we'll hear from some of our exemplars who are on the call today. Then in our November informal conversation, we did talk about evaluation and documenting the impact of the advisor partner programs. And we didn't have enough time in that one to really dive into even more details in that. So I'm hoping that we can talk about that, because again, that's really important for leadership. And then we do know that, and this is, again, not pandemic related, but certainly pandemic had something to do with it. Leadership turnover is very hard when you have to then go to new leaders to maintain that commitment, to get their commitment and help them understand why this is so important to the organization. Next slide. So I want to stop talking for a little bit and just think about, why is getting leadership buy-in so important? Well, without your leaders being committed and understanding why this is important, it's really going to be very difficult to establish a program, expand a program, or keep it sustainable. So I'm wondering if you can chat in, or if you want to raise your hand and answer one. What are your thoughts about why this is important? What brought you here today? Jasmine, I'm counting on you to watch the chat, but okay. Help move the work forwards. Okay. Great. Yes, Jennifer, that's so true. Yes, bring it beyond. Love it. Bring it beyond theory and into practice. Equity. Yes, leaders, if they don't understand what it is you're doing, you're so right. Okay, this is excellent. Yeah. Marion, so thoughtful. Yes, it can't be just check the box. Great. Okay. Next slide, Matt. Thank you, everyone. Oh, we've got someone from Brazil. That's great. Okay,
Marie,
so
I
yes.
think somebody raised their hand. I believe it was Katie. I don't know.
So I was just going to say, I mean, this is sort of basic, but so that we get included in the budget, we have to have leaders know what we're doing.
Yes, so true. That's going to come up in another slide. I want to just share these quotes. So if anybody needs to make the argument to your leaders of why is this important, here's two quotes that I just pulled. There's a lot more than this, but I thought these were very instrumental. So this first one is a quote from an Institute for Healthcare Improvement white paper that was actually published 16 years ago. So this is not new. It's just this is a difficult, challenging thing that we have to do. Leaders of organizations often cite putting patients and families in a position of real power and influence, using their wisdom and experience to redesign and improve care systems as being the single most powerful transformational change in their history. So when leaders are committed and they understand what's going on, this is what they have talked about. And then the second quote is from a more recent Canadian study of organizational capacity for engaging patient and family advisors. Interviews with 40 patient family advisors, patient engagement managers, clinicians, and executives affiliated with hospitals featuring high levels of patient engagement activity revealed multiple components of hospital patient engagement capacity organized into 4 overarching themes. And those themes were resources, training, organizational commitment, and support from staff. All of those themes all need leadership, commitment, and support. Next slide. So I'm going to very quickly go over just a few practical strategies before we jump in. I'm not an expert in this because it is challenging. I know enough to talk about it, but I think there's some probably good leaders in the audience today who we can call on. So to get buy-in, you've got to really understand what the organization's priorities and goals are so that you can assure the leaders that the advisors and partners will be working on projects that help achieve what's important to the leaders. So we don't want them doing siloed things. We want them concentrating on what's the organization's, what are the leaders' priorities and goals. Find out what metrics the leaders view as important. What do they want to see in improvement so that you can plan your efforts to align with and assess what outcomes the leaders want to see. You can ask to be included in a leadership meeting, to do a short presentation for leaders, to highlight these important aspects. How are the patient and family advisors and partners, how are they going to support the organization's priorities and goals? Why is their voice so important to integrate in change and improvement? And then share an example where advisors and partners have made a difference. If you don't have advisors, partners yet, share what others have done. So maybe take back some of the things we hear today about what others have done. And then how has that made a difference in the organization? If you do have advisors, partners, present an example that aligns with the organization's priorities and goals. So find one project that say, hey, we did this and we know this is what you're looking for. And then I know we just talked about this, or somebody just brought this up. I think it was Katie. Develop a business case to present to leaders. You have to meet them where they're at. So definitely develop the business case so that they understand resources are needed for this. It doesn't have to be overly expensive, but you really do need resources to establish, expand, or sustain a program. So you're going to have to tell them, why is this so important? What are the benefits? And then how is this going to help the organization get to where they want to be? And then create and present a realistic budget. Yes, there is a cost associated with this, but you still need to develop a budget that you can present to your leaders. Next slide. So once you've made your case to the leaders, once you've gotten in front of them and got a little bit of a commitment or maybe a lot of commitment, what's next? So you really want to establish some way of keeping a clear channel of communication with the organizational leadership. So you want to make sure that leaders are updated regularly on the work and the outcomes related to the advisor and partner efforts. You want to definitely build relationships and awareness of leaders. So invite them to attend some of your meetings. Let them see the process that you're going through so they understand that this is not like a complaint session. This is not working on things that don't mean anything to them. This is something that is very I'm trying to find the word, but I can't. Very intensive, very well, let's just move on. So invite the leaders to provide a supportive message to advisors and partners. Advisors really, and partners and staff really do appreciate getting support and a message that says, you're important to us. We're glad you're here. Keep up the good work, whatever it is, that really helps. And then measure the outcomes and document the impact. We've already talked about that a little bit before, but identify the outcomes again that align with the priorities and make sure that those are being communicated back to the leaders. How is this making a difference? Produce an annual report summarizing patient family advisors and partners efforts. So Jasmine, if you can put in the link to our annual reports, because we post annual reports on our website and encourage you to look at it. But also, if you have an annual report that summarizes your efforts with advisors and partners, we'd love to see it. We'd love to post it if possible. And then report the outcomes and activities with leadership. An annual report is great. It's great to share within the organization and outside of the organization, but it's also, you need to actually keep the leaders up to date with what the outcomes are. So get time on their schedule, if possible, maybe twice a year, to talk to them about and present to them what's going on. Next slide, please. So I just picked this resource because I just think it's a great resource. It's a self-assessment tool that includes leaders and staff and healthcare teams and patient partners. It's an assessment tool. You can use it as a discussion tool. It is great, and I highly recommend that you look at this and you use it. Okay, that's enough from me. Matt, if you can turn off the slides, I think we're going to turn to discussion now. Oh, it's good to see faces. Okay, so Tom, I know that we have some people in here who have done great work, and then we have a lot of people in here who are looking for really good ideas. Does anyone want to begin the conversation?
Can start, Marie. It's Terry Savino.
Yes, Terry, great. Thank you.
And I apologize for not having my video on. So
No
I
problem.
am currently chairing our Patient Family Advisory Council at Middlesex Health in Connecticut. And our council is going on their 12th year next month. This is a very active council. We continue to meet even through COVID. We had like 3 months where we didn't meet, and then we started meeting virtually. Currently, we are meeting hybrid. Most of the people are in person, but we do have one member that doesn't have the COVID vaccine, and that's a requirement for all volunteers. So we do offer hybrid. We are fortunate that we do have leadership involvement. Our CMO, who's also the Vice President of Quality, Patient Safety, and Patient Experience, sits on the PFAC along with myself and one hospital member at large. We have 15 community members. And one way that we engage the leadership at our hospital is we get annual reports where they're actually coming to PFAC, and we give our PFAC the opportunity in advance to ask them any questions they would like. So we have our CEO annually, we have our chief nursing officer annually, we have our medical director from the ED twice a year, but for our next year will be annually. We have our medical director for hospice twice a year, but next year will be annually. Our PFAC sit on over 20 hospital committees, including our board level quality improvement patient safety committee. Our high level patient experience committee, which is chaired by our CEO and our VP, we have 2 PFAC members on that committee, and we actually have a PFAC update that is on every single agenda at that meeting that's actually given by PFAC members. I report twice a year to Quality Improvement Committee, and there's always an update on our PFAC on that committee. We have had 3 presentations to our hospital board so far, and 3 presentations to our hospital management since PFAC has been in place since 2012. We do have an annual report, so I'm happy to send some of those to you, Marie, so you can have them. The one thing that I would love to learn from people is how you are evaluating your program. I think that's one area where we have an opportunity to improve. April is our annual year. So this is the first time, and it was basically from attending one of these webinars where I learned that we should really be looking at our hospital strategic goals and to align our PFAC goals with the hospital goals. So we will be doing that at our April meeting. When our CEO presented, we did ask him to present the strategic plan for the hospital so that our PFAC would be very knowledgeable of that.
Thank you, Terry. And
You're welcome.
And I will say, so I know Middlesex Hospital. I have seen how their leaders are very, very involved over the last 12 years. So thank you for sharing that. Kristen, I see your hand up.
Thanks. And I'm sorry, I'm having a little bit of difficulty. I'm logged in twice because I'm logged in on my computer and on my phone. We just moved offices. So I definitely want to second a lot of the things that Terry was just saying in terms of how to be on those meetings and which meetings to be on and have a PFAC represented and have annual reports. So ditto to a lot of that. And near the end of what she was saying is kind of what I was going to get into, because I think a lot of people on the call might be like, okay, well, that's all nice and good, but how do you get on these agendas? Right now, it's extremely difficult to find an in, really, to these agendas of quality, of high-level executive meetings are so jam-packed with so many competing priorities, and PFAC and patient and family engagement is oftentimes kind of like, maybe cherry on top if we have time for you. And I think that can be very frustrating because the most of us in this room know that this is not just a cherry on top. Patient experience and patient and family engagement is extremely important to safety and quality outcomes. So my biggest suggestion that I will continue to be working for and fighting for is proving that point. And I think that's very challenging because you need metrics, but we need to prove that what we are doing is absolutely significant and impactful to the quality outcomes of our patients. One of the things that we are working on is having advisors involved in sepsis work and early detection in our, what we call our CareCom area. We have tiles with a bunch of really cool statistician type stuff that help identify patients that are inpatient and will most likely develop sepsis. So how are our advisors involved in that? We're helping with that communication, helping someone understand that we're not telling you you have sepsis or that you're dirty or anything like that, because that's the perception that happens. We're coming in and explaining and communicating that we have this great technology that's helping us to keep you from getting sick. So things like that are really important, aligning with those strategic pillars, just like Terry was saying. But I think the biggest thing for leadership to even allow you in the room or put someone at the table is to really prove that it impacts outcomes, whether that be cost effectiveness or quality indicators, things like that, inpatient stay, length of stay reduction. These are the types of things that we have to show that advisors can really help with. And I have a lot of examples of that, but I won't bore you. But I would love to share some of that stuff and learn from others on what others are doing. And I'm the manager of patient and family engagement at Tampa General Hospital. And I think that we're always a little bit behind of our Northeastern partners up there. And I like to copy a lot. But we are a melting pot of people that move to Florida. And so we have a really diverse community that we represent with advisors. And it's so important to have them at the table at all of the decisions that have to do with patients. And we always use the quote, to our leadership, nothing about me without me. Remember that we are human. These are human beings that we're talking about. They're not a product or an animal. These are humans is the currency here. And we need to act that way and involve them in what is about them.
Yeah, thanks, Kristen. I think you bring up a really good point, and we started to talk about that in the November informal conversation about it not only being patient experience or a nice thing to do or an add-on or whatever, but if you are working on particular projects that have a clinical, a quality, a safety goal, then show the difference that the advisors and partners are making. Okay, Patricia.
Yes, thank you very
First,
much. Thank you. My name is Pat Powers. I'm in Peterborough, Ontario. I come at the patient advisory role from a number of perspectives. I'm a registered nurse and I nursed for 40 years before I ever had to experience healthcare from the other side and became a patient. I had a not so pleasant extended hospital stay, and in the course of discussing my issues, was invited to participate on the Patient Advisory Council, which I decided if I was going to see the things that were wrong change, I better jump into the ring. So I did that. I don't have a lot of positive outcomes to share, but I do have some things that got in the way of positive outcomes that I think may be helpful. I worked for a long time in long-term care, where in Ontario for many years we had legislated resident councils, and the resident councils we were required to see that they had meetings, that they had minutes, that as an organization we listened to them and implemented their recommendations wherever we could, and where we could not, that we would provide an explanation to them of alternatives or why it wasn't practical for us to implement. So that's been in place for many, many years. As an executive in that organization, I had to push for those voices to be heard with the chief executive of my organization. So I really had to be a representative for the residents in that regard. So it was effective at times it wasn't. But I think that my job was to make sure that our residents knew their voices were being heard. Further to that, I worked as a number of years as an inspector in the long-term care sector. And part of my role there was to look at resident councils in every facility I went in to see that residents were given the opportunity to speak and be heard, and that there was action taken on. So it's not 100%, but it's I think created a more respectful environment for the residents and an awareness, if nothing else. I know that in my nursing days, there wasn't a huge awareness of patient rights, and back in the olden days. But I do think in many ways there was a more respectful relationship between staff and patients, which isn't always there today. And so the patients were heard, and maybe not a more direct way, but the patient voice was heard. And as a nurse, I feel that was my responsibility, and I did that. In my role as on the Patient Advisory Council in the facility that I had an extended stay, a leader, a manager in the facility was the chair of the PFAC. So anything that came up with the PFAC was filtered before it left our meetings. It didn't go any further if it wasn't good. So I think I would caution to have that meeting chaired. I know that's not everywhere because I've had some very good support from people with experience beyond that who've directed me to different organizations that are very successful. But and I think one of the biggest things that I did, I volunteered a fair bit of time and really took it very seriously because I think healthcare is a big concern here as it is everywhere right now. We're all very nervous about what the future holds. But you know, the biggest thing was that the organization was struggling with how to reconcile patient input and perspective with operations. They saw it as, to use their words, overstepping operations. And that's when I made my exit, because I thought this is a check the box. We have it, and we're just so happy to have you here, but be quiet. I think that when you talk about evaluating how your program's going, I think that's really, I've had some more positive experiences that, you know, in a sort of smaller scale, and that was my letdown and sort of the cautions that I would say that really need, when the more you look at the healthcare system, the more you realize that patient perspective is so critical. As a patient, I had no idea how important that perspective was until I was in that bed. I thought I knew, but I didn't. So I just encourage
Pat. I know we have a number of hands up, so I want to make sure.
Thank you very much. Thank you.
Yeah, no, thank you very much for sharing. Marcella?
Hi, can everyone hear me?
Yes.
I am the Brazilian one. Thank you so much for receiving me. It's such a pleasure to hear from you and to learn from you. I just want to say that I feel less lonely when I see you doing these great jobs that you're doing. It's the first time we're doing that in Brazil. And I am still learning how to not be hated in my hospital, because we are dealing with a very hard time about getting accepted, and it feels like I am an outsider, an FBI member, and I am there to fiscalize everyone. And they are very thinking about if you're gonna like if they are gonna like me or not. And it's been quite hard. It's my 4th month since I was hired. I was hired by the CEO, and doing something for the first time in a country is very hard. So if you have any tips for me, any advice, I would be so thankful for you. And I am very glad about not feeling so lonely. I am 86 Fahrenheit here, and I feel very different from all of you that are running paths so in front of me. But I think that if you have get there, I may get there too, and make a good partnership with the families for our kids here in Brazil. So thank you so much.
Thank you. And Marcella, are you
for me?
Yeah, are you a member of the PFCC Connect online learning community?
Yes, and I am learning a lot.
Is a great place. Okay,
all the
perfect.
materials. It's such a rich resources. Thank you so much.
Okay.
Thank you for all you are doing for us in here.
Great. Thank you. Julie.
Hi, I'm Julie Piazza. I'm from the Office of Patient Experience at University of Michigan Health, Ann Arbor, Michigan. We're a large academic medical center, and we have a large number of PFACs across our system in ambulatory hospital representation. But I serve as a liaison in about 7 of those advisory councils. And then we have a lead PFAC lead program that we started recently in the past year to bring the co-chairs from these various PFACs across the system to be able to share ideas and support, which has really been really beneficial. Many of those PFACs have done SWOT analysis, looking at what they are representing and how they can look at the strengths, weaknesses, opportunities, and threats that they can get involved in. And most recently, the Mott Children's Hospital Patient Family Advisory Council, Mott is doing for the first time a quality and safety poster day in the lobby of the institution. And one of the things that the advisors were saying was, we really want to know what's happening, what we can contribute to, lots of the comments that have been shared already, and how can we bring that forth and be more transparent about it. So we are contributing, and they said, let's contribute a poster. So the poster they are focused on is transition of care from pediatric to adult care, which is a big, huge leap. And I'm in the midst of research on that very topic, but I think looking at complex care needs across various services, it's challenging to be able to identify that, but this group really wants to honor and develop a diploma and honor that journey and support and recognition and develop curriculum to be able to attain that. And that all really came from the SWOT analysis, having the conversations and looking at ways that they could make a difference. And then the posters will be shared on the floors and other opportunities to share too. And thanks again for this opportunity. It's great.
No, that's great ideas there, Julie. And I know we've had some questions about getting physician buy-in as well, but I want to move to the people whose hands are up. I know that I think Darcel just put a chat about physicians, and I think, you know, getting them grand rounds, it's excellent. Patricia?
Yes. Hey, I'm Patricia from Tallahassee Memorial Healthcare. I was actually going to address that as well, because we were trying to figure out how to get physician buy-in. And what we did was similar to what others have been saying, is we developed poster presentations based on the quality improvement projects that we did. So we have a research day where we have all of the physician residents and nursing residents and the physicians all come to that. So I think that really generated a lot of talk about, well, what is the PFAC? We opened a new hospital, so that was sort of the impetus of our starting our PFAC, and they had a really big say in how the hospital was designed, like from the architectural plans right at the very beginning. So that was sort of our way to get buy-in from the physicians as well.
Yeah. You make a good point there, because somebody asked a question about, you know, costs and, you know, can you talk a little bit about the difference that advisors and partners make in, for instance, facility design? Is there something, are there things and perspectives and insights that they share that bring those costs down? Have you had that experience?
We definitely did at our Muschamp Center. We had the ICU. Our new building was an ICU and surgery center, and the PFAC was very utilized in saying, you know, that I think, you know, you don't need the best beds. They actually got in the beds, and they had 3 different types of beds: the most expensive, the middle, and the and not as expensive. And really, they were saying that they don't need all the bells and whistles that are on the other beds. So they actually saved money that way. They had ideas in the ICU to sort of have it sectioned off, where you would have a clinical area, the patient area, and then a family area. And the architect didn't even think about that. And they said, well, in the family area, we'd like to have a table and chairs that turns into a double bed. And we would like to have chargers and a little desk and something that we can have a little locker in there. So all these things, the architects were just dumbfounded and said, this is exactly why we need patients and families to come in and talk to us about, you know, what would be the best things in an intensive care.
That's a great example for people to share with their leaders. Barbara.
Hi, this is Barb Forrest. I'm one of the PFAC members of the Bellingham, Washington, Peace Health St. Joseph Medical Center. And I want to give a shout out to you and also to Bev Johnson, who I met over 20 years ago. Bev and I were at a forum together in Portland, Oregon, and she was the inspiration for me starting a PFAC at our one and only hospital in our entire county. And that was important. We had such amazing leadership buy-in at that time. We actually became the first, I believe, in the country, the first PFAC to put a representative, a patient, on medical exec council. And that patient sat there during credentialing of physicians, which is huge when it comes to transparency. Our problem, as I see it, is that we have had what I call regime changes in the past 20 years, leadership changes, huge changes in everything from CEO, administration, all the way down to patient experience, CNOs, CMOs. And every time we just seem to go a little forward. We go one step forward and 2 steps backward. So my question to you is, how do we, without starting from ground zero every time we have new leadership, how do we create a vehicle to share what we mean to them and what they mean to us and to partner?
Yeah. I'm gonna call on Angela, and then maybe others in this conversation could respond to what Barb just asked. Angela, good to see you.
It's great to be here, and it's great to see everybody, and I'm typing away so many great ideas. So one of the things, Barbara, I really, really feel your pain. We've gone through significant challenges right up to the fact that my boss is retiring in about a week, who has been a huge mentor and advocate for patient family-centered care within our organization over the years. And we've lost a few of those sort of people who hold the knowledge over the years. And one of the ways that we're sort of approaching that is we try to do what I would call a warm handoff. And so she has introduced, so we've gone from having I report to the Executive VP Quality and Safety, but I will now be reporting to the Executive VP Medical and Academic Affairs and the Chief of Staff role. And so he will be, we've already had a handoff. I've had the opportunity to share information. I share the annual reports, agendas, as well from our 3 different PFACs with him. The question is asked, how can he support us? What can we do together? What do I need from him? And when he asked, I said, I need you to show up. I need you to be at the PFAC meetings as our executive sponsor. I know you're a really busy guy, and he is, but we have our executive sponsor come to every PFAC meeting and share an organizational update, so we know what the priorities of the organization are. And then when other levels of when there's other levels of change within the organization at the leadership. So for example, I will have a meeting on Monday with a new patient relations person. The director will do an introduction and we'll have those conversations. So we try to do that, but it's labor intensive, right? To do that sort of on every kind of thing. So I too am exploring how do we continue to transfer the knowledge to new people, and I actually basically feel as though it's not just my job, it's everyone's job in the organization to be reiterating and reinforcing how important this is and that it's part of how they work. So we always look at how can we embed this in existing structures. So if somebody's working on a pamphlet, a patient brochure, resources, one of the steps is that it has to go through our PFAC. It has to have had a patient perspective as part of the process. That immediately brings to attention that we exist and that you have to hear from us. when you can't get your brochure or okayed without somebody having had a patient perspective on it. So there are sort of those things that we try to embed in existing structures. One of the other ways that we get attention of doctors is that our PFAC sponsors an Exceptional Healer Award, where we accept nominations for credentialed healthcare providers that show exceptional family-centered care. And all of the nominations have to be supported by patients and families. So we get wonderful, amazing stories about patient-centered practitioners, and so that gets attention as well. It's supported by the CEO and the executive and the board, and they get a plaque, and there's a presentation, and so there's all that. And we also have a patient and family-centered care project grant, and they can submit their ideas for patient-centered projects, and a committee of patient advisors chooses who will receive the funding from those applications. So things like that, where it's kind of like we're reinforcing really great patient-centered work within the organization, we're highlighting it, and sort of showing our partnership with people helps for sure to raise, I think, the profile a little bit as well.
Thank you, Angela. Great ideas too. And I love the, acknowledging the PFCC with staff and even leaders. I mean, I think you can do that. And we've seen great organizations do that. I don't want to mispronounce your name. Is it Salome?
Hi, my name is Salome.
Salome, thank you. I did mispronounce it. Okay, great. Yes. What's on your mind?
We wanted to share, so I'm Magali Flores Nunez, and Salome Aaron, who's here with us too, and I are part of the Seattle Children's Family Advisory Partnerships team. I'm the manager, and one of the thoughts that I had that was prompted by someone who, I think it was Barbara, who shared about changing leadership, and it prompted me to think about one of our staff family advisors. So we have a pretty robust program of over 215 family advisors that are involved in our cohort throughout the hospital. And this has been, over 27 years in the making. So pretty proud of our program. And just recently, we added one of our family advisors to our day one. So in the orientation for all staff, which includes leadership, everyone has to go through a day one onboarding. And that's put on by our learning team here at the hospital. And we have one of our staff family advisors sit on that day one. She was trained as a facilitator. So she facilitates part of the information that every staff member has to hear on day one. And she gets 10 minutes to talk about our family advisory program and the impact that families make. So that, I think, is an opportunity to kind of plant that seed for all staff, including leadership. And we also have a family advisor panel in day one or onboarding for nurses, for all nurses, and then some residents and surgical residents. So trying to get into the clinical education piece up front, I think just sets the tone, right? That we are, that family-centered care is a cornerstone of our pillars. This is how we function here. This is part of our culture. And it's not the only tool to use, but I wanted to offer that.
Yeah, no, thank you. That's a great example of making sure that the entire organization knows about the patient and family advisor. Yes, so that's wonderful.
And one question I have for the group in terms of what we're struggling with is that we are at a point where we have incredible leadership buy-in, and that's been a lot of years in the making. We have family advisors, as I shared, involved all across the hospital, in committees, family advisory boards, unit-specific advisory boards, and we provide stipends for all of our family advisors. And so we're at a point where we have the budget, we have a lot of folks involved and buy-in. And I think the metrics, impact, and outcomes that family advisors are influencing are still at the forefront of our improvement work. So hearing from all of you today has been really helpful. And if anyone has additional resources of your annual reports of metrics that you think have been successful in communicating to your leadership, because as was expressed, we're all going through, healthcare as a sector is going through a lot of cuts. So we want to make sure that we keep what we have and the progress we've made. Thank you.
Yes, thank you. Anyone have a response to that? Oh, you're on mute. Oh, are you leaving, Barb? Oh. Oh. Just saying thank you. Okay. Anyone have a response to Salome's question? No. Just so you know this, yeah, Carla.
Hi, I'm Carla Isolt. I'm at Cincinnati Children's, and we use Salesforce for our tracking, and we track everything that our family partners do for every event, meetings, projects. We have a dashboard that we can, every information we put in there, we can extract. So we have gender, race, the hours they volunteer, the projects they volunteer. We can get so detailed to like the start time to the end time. And every month we send to our boss the hours that our family partners participate for the whole month and the projects they do and all the events we have. So we love our dashboard and it shows and we can see the progress. If a family partner is in too many projects, we can see that too. So we try not to engage them in too much and then maybe reach out to others. If we have a specific project where they want a specific family in a specific department, we just search what family partners have gone to that department, and we don't have to be contacting our family partners. Has anybody has experience in this? We can just reach out to the ones that we have already a tracking of what departments they have been seen at. So we love Salesforce, and I'll be happy to chat more with you. I put my email in there somewhere in the chat.
Good to see some faces from Cincinnati. I know Pam Dardis, who's on the call, has been working very closely with Cincinnati on some PFAC and diversity, equity, and inclusion projects. So great. All right, we've got, yes.
Marie, if we just have a quick minute, I wanted to bring up a question that's sort of been like a running theme in the chat.
Sure, yes.
It's about leadership motivation. Specifically, are there research funds or accreditation or anything along those lines that require patient and family engagement? And, if so, do folks have ideas about that to share, in terms of getting leadership motivation on that end?
Thanks for bringing that up, Jasmine. Deborah? We get Deborah.
Sorry, I couldn't get off mute. I'm sorry.
That's okay. And Janice, you're next. So yes.
So I work at Jersey Shore University Medical Center in Neptune, New Jersey, part of the Hackensack Meridian Health Network. We actually are magnet designated. And so we had, I think, 4 members of our PFAC meet with the magnet surveyors and explain what they do. So that, in response to that last question, we involve them in our magnet survey.
Thank you. And I've heard from some places that when Joint Commission comes in, they do have them meet with their patient and family advisors as well, which is just another thing to keep in mind. Okay, Janice, you're the last one. So, oh wait, no, I see Bruce too. So we'll go with both of you. Go ahead, Janice.
Yeah, I just want to say I know somebody that serves on the Joint Commission and has for years as an advisor, a couple of people actually, and I think we're still waiting to see how that happens with NQF, what it'll look like. What I wanted to mention is something I think is really important with PFACs is I haven't seen it officially like a training program or something, but mentoring the new PFAC advisors, because sometimes people come in and they literally are alone, right? And nobody really bonds with them. And I think that's one reason they quit, as well as it happens when if somebody perhaps comes in because of a specific situation, and once that kind of goes off their radar, they then leave. So I think some sort of informal mentoring program where is really beneficial, where even if it's somebody that somebody could call that's been on there for a while, like a peer mentor, I think is extremely important. I was going to say something else, but that's about it. Oh, I know what else. Is I think our PFACs is I've worked with IPFCC for over a decade too, and some of us have really moved on from patient family advisors into the national and international atmosphere, and we serve as advisors on various committees, and so this is something that might be smart to share about too, because I'm serving on like National Children's Committee, or I've served on ABIM, American College of Physicians. That really makes a difference, having that patient voice at the higher levels too. So that might be a future opportunity.
Great. Thank you, Janice. So good to see you. Bruce, you're the last one in the queue.
So I also serve with Barb with Peace Health. I've observed in the past marketing attempts that where PFAC is not necessarily consulted, the message to the public isn't necessarily representative of what's going on. I see a lot of opportunities for there to be integration between marketing and patient advisors. And in our case, it's human experience. So it combines the physicians, clinicians, along with patients all under one umbrella. So I'm just bringing this up as an issue. I think it's a lot of opportunity for us to be able to piggyback and integrate with marketing. If marketing is willing to take a look at the accomplishments that are happening and take advantage of the metrics that we have, it may be another way to gain leadership support.
Yeah, you're bringing up a great point. And sometimes I hear that marketing is a barrier and because they want to get too involved in what the PFACs, the patient family advisors are bringing up. And sometimes they can be a very good friend and good resource. All right, Matt, if you can bring the slides up, because we're going to finish. Sure. So healthcare excellence is in here. A resource for leaders. It is for purchase from IPFCC, but it's wonderful. And this last one, the Kansas Healthcare Collaborative, getting leadership buy-in. It was done by Tiffany Christensen, who unfortunately is no longer with us, but it's an excellent video to watch. Next slide, please. Okay, so we love your feedback. We use your feedback. If you can, please complete the evaluation using that link, or you can use the QR code. We're going to keep this up here for a little bit, and Jasmine's going to post in the chat the link to the survey so you all can do that. Yes, Deborah, the slides, the recording, and the chat will be shared. And I'm going to say, because I don't want to put Matt on the spot, but I'll say early next week sometime. Oh, thanks, Janice, for putting in that resource. So everything in the chat will be available to you. Okay, so next slide, and then we're going to finish up. So we will hold our next informal conversation in May. The date and the topic is to be determined. As I've already said, everything will be posted onto the PFCC Connect site. If you have resources, if you have anything that we talked about today that you want to share, we can post it onto PFCC Connect. That includes annual reports. We'd love to see more annual reports come in. And then you can continue this discussion in PFCC Connect. If you want to email resources and any links, just send them to me. That's my email down there. All right. Thank you, everyone, for attending. We're 1 minute over time. I apologize for that. I hope this was very informative. I felt it was for me. So thank you.